here. So I'm sure everybody heard that. Ray, it's all yours. Thank you.
Thanks so much, Greg. I really appreciate it. I'm hoping everybody can hear me okay. Typically, I would tell people to take themselves off of mute and let me know, but I know we have about 50 people here. So we're not all going to go off of mute to let me know that you can hear me. I will tell you that when Greg reached out to me, he said, I'd love to have you speak at this particular conference. And what would you like to talk about? And it's typical because I'm an old EMS guy. I said, yeah, we'll figure something out. And then about a week and a half later, Greg reached out to me and said, what do you want to talk about? And I said, EMS and public health interaction. And he said, perfect. Thanks so much for making it work. And I kind of laughed and said, you got it, because EMS and public health interaction is probably one of my biggest pet peeves. And I'll explain why in a couple of minutes. First, I will, with the usual caveats, I will let you know that much like many in EMS, I have tremendous ADD. So you will hear stories and things like that as I jump around through this presentation, but I do hope you find it informative. So I'm going to try to advance my slides. Please let me know if that's working. Either send me a chat or someone can come off of mute or however you want to handle it. There's a chat. Yes. Thank you, Melissa. So who am I? So my particular journey in this interesting career I've had started up there in the upper left-hand corner with me looking at the camera with my flock of seagulls haircut. That's an ambulance in Teaneck, New Jersey. And I volunteered in Teaneck for 18 years. But during that time, I also went to go work in Newark, New Jersey, which is the ambulance on the lower left-hand corner, the orange and yellow one. Newark is the type of place where they give you the test right before they teach you the lesson. And I learned many, many lessons there. I also went to go work in the next system over from Newark, which is in Irvington. And the name of the system was MTAC. And fun fact about that picture, the only picture I could find online of any of our ambulances was behind crime scene tape. That really should tell you everything you need to know about Irvington and the EMS system there. Along the way, I also finished a long drawn out bachelor's degree. I believe it took me 7 years. And started a master's in public health and completed that. I went to go work in the Hudson Valley. I was the regional EMS council director. I wrote for EMS Magazine. I wrote for GEMS. I wrote for the EMS Insider. And I was speaking at a lot of different conferences as well. My journey continued to Prince George's County, Maryland, where I was the chief of public health preparedness. After that, I was the state EMS director in the state of Connecticut. If you look at that picture, my hair is definitely a little darker there. And all the way there on the right, me speaking at the Capitol, that's in my role as the Deputy Secretary of Health here in the Commonwealth of Pennsylvania. And it's interesting because one of the things that when I was talking with Greg is, I know we are talking about EMS and public health interaction, but one of the things that I've always learned from is when I get to see somebody or speak to somebody at a conference like this who really brings a different depth of knowledge than I do to a particular subject. So you're all very, what's the word I'm looking for, privileged to be having. I know you had some great presentations yesterday. Greg was telling Dr. Giordano and myself a little bit about Ming Lin's presentation. And I know after I go, Dr. Giordano is going to be speaking. I know there's an ASPR update. And I know that sometime later, you're going to hear from Nikhil Natarajan, the person I hold in the highest of regards. And it was around 2009, I walked into a meeting in DC, and I heard Rich Serino say something exceptionally on point. And what he said was preparedness is about relationships. And it was very interesting because later I'm going to tell you about a lack of understanding about public health. But Rich Serino said this, it was right around the time that we were looking at H1N1. And about 2 weekends later, I was up in northern New Jersey visiting family, and it was a Saturday night, and I got a message from the major in charge of fire EMS in PG County, and he said, we need to have a conversation. And I said, okay, no problem. I said, who do we need there? He goes, PD, police, emergency management, healthcare coalition, you and me. And we made that conference call work as I was driving down 95 to get from northern New Jersey back to Prince George's County, as we were starting to see H1N1 impact the national capital region. And I think that really speaks to the relationships. Here we were on a Sunday, it's probably 11:30 in the morning. I will be honest with you all, I would have much rather have been enjoying a bagel, some coffee, because I'm from northern New Jersey, I'll say maybe some onion and lox on that bagel with cream cheese. But I would have much preferred been doing that. But here we were, exercising our relationships and making sure that the interaction between a police department, a fire department, EMS system, health department, healthcare coalition, and emergency management were working. Now, typically in this part of the presentation, I will ask people if they also have a confession to make, but I'll make the first confession. And that is that when I was working as an EMS provider, I literally had no idea what public health did. I'm not kidding with any of you. It was only later that I started to learn about issues like the social determinants of health, that I started to learn about issues like epidemiological investigations, like that I started to learn about things like state health labs and the things that they picked apart. But here I was, an EMS provider in Newark, New Jersey, pretty busy system with a lot going on, and I knew nothing about public health. Similarly, I also didn't know that in most areas, the regulation of EMS falls under public health. So that means in an emergency, we fall under ESF 8. Some of you may know this, some of you may not. But as I started to really wrap my brain around this, it really kind of stunned me. It actually made me, for lack of a better term, laugh. But it also made me think about what potentially public health doesn't know about EMS. And I will tell you a short story, also H1N1 based, where I was in Prince George's County, and I was meeting with, I wasn't a director, I was what was considered a chief, which was below a director. And I was meeting with all of the directors and the health officer as H1N1 numbers were starting to increase in the national capital region. And everybody was discussing various areas where they could make a difference. They were discussing PPE. We were discussing the potential for mass vaccination of our entire population, which in Prince George's County is just over 1 million. And we were discussing all these different elements. And all of a sudden, our health officer, who has a deep booming voice, unlike my own nasal voice, said, "I have the answer to all of our problems." And we looked at him and he said, "The governor just signed an emergency declaration that allows all EMS providers to become emergency vaccinators." And he started going on and on about how what we would do is pivot and utilize the Prince George's County Fire EMS system to, instead of nurses, instead of anything else, to assure that we had enough people to vaccinate our 1 million. And this was one of those very uncomfortable moments for me, because I knew something, but I also knew that my boss didn't understand a particular element of EMS, and I was going to have to educate him. And before we started running away with these plans, I was going to have to educate him in public. And so, like the moron I am, I raised my hand and he said, "Yes, Ray." And I said, "I'm not sure you read that correctly from the governor's office. I think he only signed that all ALS providers can be emergency vaccinators." And he looked at me and said, "What's the difference?" And so there I was, a fairly young and obviously big-mouthed employee, educating our health officer, who's an MD, on the difference between basic life support and advanced life support. And it really brought a certain thought process to me about the fact that, and again, I'm generalizing for the sake of the audience, but I'm also generalizing because it's generally what I've seen, that for the most part, public health doesn't understand the capability and capacity of the EMS system, nor the flexibility of the EMS system. But at the same time, there are many times that EMS providers don't understand the roles, the structure, or even various elements of their public health departments. And these can be city, county, regional, or even statewide. So we have this very strange relationship where we have two different entities that definitely have some overlap, that definitely have missions that are very close to each other. But at the same time, we just sometimes don't understand what the other is or does. And so what is public health? Well, CDC says it's the science of impacting and improving the health of people and their communities. Now, I've worked in public health. As I said before, I have a master's in public health, and I'm currently a doctoral candidate in public health at the Indiana University, the Fairbanks School of Public Health. And so I like the CDC's definition. I'm going to go back to that for a minute. If we're talking about a dry definition, but if we're talking about something that's real, if we're talking about what public health really does and is, frankly, this is what they do. And so when we think about things pre-COVID, and we'll talk about pre-COVID and post-COVID or COVID in just a moment, but when we think about things pre-COVID, this is what public health is and does. There's a ton of environmental health going on in most public health departments. That's in regard to lead, PFAS, even things like fracking studies. Our epidemiology areas definitely look at outbreaks. There's always something going on. And one of the things that I always say about public health is that public health has a peacetime and a wartime mission. So most of the areas that you'll see, whether that's in regard to surveillance, whether that's in regard to a state laboratory, whether that's in regard to health promotion, or even emergency preparedness, are going on in the background in your public health departments right now. And so you will have emergency preparedness elements that are preparing for things like mass vaccination, mass dispensing of antivirals, even communication plans, ESF8 plans. These are all areas where public health is engaged on a day-to-day basis. If we were in person, I would actually ask people, but I'll ask people, please jump in on chat. And I should have mentioned this before. If you have questions, if you don't agree with what I'm saying, or if you do agree with what I'm saying, I want to hear from you. And the feedback loop on Zoom is such that I probably can't hear from each one of you in regard to your voice. But if you have questions or anything like that, please jump in. So as we look at the structure of public health, and I apologize for the absolute fuzziness of this slide, we do see various areas. And again, it's just a template structure where this is what public health is and does. So whether that's in regard to surveillance and epidemiology, or whether it's in regard to assuring that the agency is prepared for emergencies, or whether that's in regard to health promotion with behavioral health or chronic disease clinics, or whether that's in regard to environmental health, this is what typical public health departments look like. And if I could point my camera over to that wall, I will tell you that I have two different boards that you would see, two whiteboards. One is my tactics board and one is my strategy board. But the strategy board speaks about all the different areas that I oversee here. So there are 5 bureaus that I'm in charge of: epidemiology, the state laboratory, emergency medical services, public health preparedness, and community health. But it isn't, they're not listed as that. What they're listed as is all of our issues and our goals and objectives. Because as we look at public health, we're not looking at the right now. We can't even afford to look into the past. What we need to do in public health is we need to look at the present and the future. And all the more so in light of what we're seeing during COVID. And what we're seeing during COVID is probably, and I will not call on Dr. Giordano, but I will say that probably for the first time in recent memory, public health is really at the center of the stage. And so the question becomes, as people on this call, but also as a public health practitioner, what happens next? What do you do if you work in EMS? What do you do if you work in emergency management? What do you do as a next step in regard to what public health is seeing right now? And as I look, and as I say to you, as I define public health, as I tell you what public health does, and as I look at the public health structure, I want you all to be thinking to yourself, what does this do for me? What am I going to do next? And how do I interact with public health? And as we look at EMS, it kind of straddles two worlds, for lack of a better term. We're a safety net. We are. And more often than not, even in today's world with MIH and community paramedicine, we're the safety net for the most vulnerable. But at the same time, we're also very specific. We deliver one patient care at a time. And so EMS providers, EMS managers, EMS leaders have to think out of the box and think, how does EMS fit into the global structure that is public health? And we've had a lot of different times to kind of, for lack of a better term, test this out. There are a lot of different things that have occurred that we've been around for that we have to ask ourselves about. And one of them is, the first one that I think of is SARS. And so I can tell you that prior to SARS, I cannot remember a coordination. And again, some people on the call may, and again, please feel free to use the chat function. I keep checking it. And I'm just kind of hoping that Greg doesn't drop any more dad jokes on the chat function. So I cannot remember the coordination across agencies, including public health, prior to SARS. And when I deliver this presentation about pandemics, and I deliver a presentation about pandemics, I say that it's interesting because there was a specific EMS lesson from SARS. And it was that EMS has to be at the decision-making table. EMS needs to be on the same page as public health and hospitals, and paramedics have a role in reporting outbreaks from the front line. And this is kind of interesting because after 9/11, we really moved into a different era in regard to what we were seeing on disaster management, emergency management, and even public health preparedness. And there were a lot of people, sorry, coffee moment. And there were a lot of entities that weren't used to the public health preparedness role. I can tell you many times in my roles in both public health and EMS, I've had people ask me, isn't that an emergency management role? And I will tell you that my personal feeling is that there's nobody better to represent public health preparedness than a public health department. And so here we were after SARS trying to learn from our after action report. So I don't know if anybody remembers H1N1. I'm hoping you do. And H1N1 taught us a lot of valuable lessons in regard to how we were going to handle a pandemic, but also in regard to how we were going to reach out to both the public and those supporting agencies. I can tell you that this was the first time that in my career, and again, I believe it happened right after 9/11 as well, but I was not impacted by it then, that we saw a push out of antiviral medications from the CDC's Strategic National Stockpile. And as is typical, and I'm definitely expecting some comments on chat on this one, it was a Friday afternoon, and I got an email from our Maryland Department of Health and Mental Hygiene SNS coordinator. And he said, are you available for a phone call? It is extremely important. And Friday afternoon, here I was, and I said, yes, let me grab our health officer and our deputy health officer. Went to the health officer's office, got on a phone call with the 23 other jurisdictions in Maryland, and heard that CDC was pushing out the SNS to various state health departments for a close hold. We also saw the use of antiviral drugs in school closures. And there were a lot of countries that had confirmed H1N1 infection that utilized various public health measures that we hadn't seen utilized before, but we knew that those were in our bag of tricks. And some of that included isolation and quarantine, some of that included antivirals, and some of that included both school closures as well as social distancing measures. It's really bad to cough while you're talking about, a pandemic, not a good move. But here we were facing down what we thought was a pandemic, and we were extremely concerned about it. What else did we see? Well, as I said before, I'm trying to move this around a little bit so I can see better. Thanks. Some state EMS offices allowed providers to function as vaccinators under emergency orders. And there are some really interesting examples, and I will tell people that you should probably go look at the literature from these states, Maryland, New York State, Ohio, and other areas that allowed ALS providers to vaccinate under emergency orders. And probably one of the most interesting and flexible things that I saw come out of it was Minnesota, where the state statute authorized EMS services to operate in ways that were not normally authorized. And that meant tiered responses, it meant crew configurations, and it meant other things as well. And I have to tell you that I've been delivering some sort of presentation like this probably for about the last 10 to 12 years. And in my time as the Connecticut State EMS Director, I used the example from Minnesota during a very large snowstorm, which put 2 to 4 feet of snow. I realize the audience I'm speaking to, I realize that in your world, 2 to 4 feet of snow might not be the significant thing that it was in Connecticut, and I'm feeling a little chagrined at the moment. But we utilized some of the examples from Minnesota to ask our governor to allow us to also change statute under emergency orders for limited times. And so one of the things that we got the governor to do was to allow agencies to not respond during the height of this particular blizzard. And another thing was we got the governor to allow us to suspend the statute that said that you had to transport a patient in an ambulance because there were certain patients who were in places where only an SUV could reach. But this is an example of how this is a statute that governs EMS practice, but it's governed by public health, and you needed to have a knowledge of what public health does in order to change it. I'll also tell you that as we look at that EMS and public health interaction, we have to talk about COVID. And if you don't, you're really ignoring a big piece of the pie. And so we know that COVID tested us in the craziest of ways. And some of that was in regard to our supply chain. Some of that was in regard to critical infrastructure. In regard to EMS, first we saw a tremendous bump up in regard to the number of calls we were going to, both COVID and otherwise, or COVID and suspected COVID. And then there were areas of the country where there were almost no 911 calls after that initial spike. So what some areas saw was a tremendous spike up in regard to the number of calls they were seeing, and then it dropped precipitously. And at the same time, we also saw lots of different realities in regard to COVID. One of the things we saw here in Pennsylvania was our opioid crisis numbers went up tremendously during this time because people were afraid to call 911. People were afraid to get transported to the hospital. There was a lot of fear in those days. And at the same time, we also had the reality of PPE simply not being available. On a personal note, I will let people know that the last time I was on an ambulance, working on an ambulance, was 2008. That doesn't mean I didn't keep various PPE either in my car or in my apartment. And as I said, on a personal note, we lost my father way at the beginning of COVID. And it was the end of March. And I drove up from Harrisburg to my mom and dad's house in Teaneck, New Jersey. And as I was approaching the house, remember it was March of 2020, I went into my PPE stock and grabbed an N95 and gloves. And as I put the N95 on, I took a breath and my glasses didn't fog up. And I thought to myself, okay, if I remember correctly from when I was taught how to use this, that means that I put it on correctly. But it's kind of scary that A, we were utilizing PPE that we potentially hadn't utilized in a long time. And then B, we were looking at the availability of that PPE to be, I said measured in days rather than years, but I would have measured it in weeks. On top of which, EMS was pushed into positions that we probably hadn't thought of being in before. But I will tell you this, as you look to your roles as EMS providers, and you look at interaction with public health systems, there's an interesting flexibility that EMS has and always had. And Greg and Lorraine are the two people on the call who I know. but I'll be very clear. I've always said that EMS is public health's secret weapon. And EMS providers and managers bring something to the table that most public health departments don't otherwise have. And sometimes that can be an expertise in something like fit testing. I will tell you that EMS providers are typically expert in triaging. And in COVID realities, these various strengths have really been brought to bear, not only as fit testers and contact tracers, but also in regard to areas where potentially we've utilized nursing staff before, public health screenings, fever checks, even patient education. And yeah, we've been vaccinators as well. I have probably, okay, can someone just say something on chat so I know I'm not alone here? But I have also, thank you. I have also said that EMS providers are the Swiss Army knife of public health. So we're not only the secret weapon, but we're the Swiss Army knife. We get things done. Hi, I'm not alone. Thank you. Those are great messages. But we get things done. And I want to talk a little bit about that more later on. And so, yeah, I think that there are also, and there's something else I wanted to talk about right in between flexibility and lessons learned. And that is that there are other areas where EMS providers and public health have come together in a non-emergency way. And so whether that's in regard to the fact that we're seeing people age and they're aging at home and EMS needs to work with public health in regard to that, that's one area. Whether it's in regard to mobile integrated healthcare and community paramedicine and really taking those initiatives to the next level, that's another area. But and I know that there are various programs that speak about bike safety and fall prevention and areas like that. But by the way, this is the moment, feel free on chat, not just writing hi, if you are privy to another program like that where EMS and public health come together, feel free to jump in. But when I think about that, when I think about what EMS brings to the table, that kind of goes back to the, this kind of goes back to the flexibility that we showed during COVID. So it's that we are willing to do what we have to do to serve our populace. And sometimes that's in regard to drowning prevention, fall prevention, bike safety, community paramedicine, other areas like that. And so as I talk about these things, and as I'm mentioning them, I want to be very clear. The EMS and public health relationship isn't just disaster only. The EMS and public health relationship has to be a day-to-day relationship. It has to be that sort of thing where you know who the other person is. And so when I look at the EMS lessons from pandemics, I think to myself, these are areas where EMS providers have to understand certain elements. Those elements include having an active, robust relationship with local organizations. When I worked in Prince George's County, we had this, okay, I am asking people to jump in on chat. How many people have ever heard of a mega church? You can also come off of mute. Either way works. Okay, thank you. Wow, this is great. So I was from North Jersey. Okay, this is great. I'm looking at the comments. I'm from North Jersey. I got down to Prince George's County, Maryland, and I had never heard of a mega church in my life. I just hadn't. And I was talking to our health officer, and I said, I passed by this huge, huge entity, and it looks like it's a place of worship. And he goes, yeah, that's a mega church. And I said, okay, can you tell me what that is? And he said, yeah, it's a church that has services. And I think on Sundays, they served over 5,000 constituents. And I was blown away. And as we looked at our closed pod plan in Prince George's County, and we realized we were going to have to service 1 million people if we had any type of public health emergency, one of the areas we went to were mega churches. So we went to the, obviously we went to NASA, is in Prince George's County, and there are a couple of other government agencies in Prince George's County, and the University of Maryland is in Prince George's County. But drums please, when we went to the mega churches and we said, you have a role in assisting us in regard to the public health emergency readiness of your congregation, everybody climbed on board. Everybody wanted to be a part of this. So that speaks to those active, robust relationships with local organizations. In addition, there's really no substitute for being able to pick up a phone and speak with somebody you know and exercise with. And this speaks to capability and capacity. So there are a lot of entities out there who will tell you about what they can do. As a matter of fact, to be really honest with you, yesterday I was having a conversation. I was actually in State College speaking at our statewide advisory committee on preparedness. And one of the people was talking about how they, in an emergency, they didn't have enough people to do the things that they needed to do. And I laughed and I said, were you willing to go to another state for those things? Were you willing to go to locals? And we had a long conversation about it. But at the end of the day, this is about your lessons here are about being able to pick up a phone, speak to someone, and knowing their capabilities and their capacity, and knowing what they're going to be able to realistically do and what they can't. And so I will say this, this is the moment. This is the moment for EMS providers to reach out to the people they know in public health. And for years, I've been delivering presentations at EMS and public health conferences. And at EMS conferences, I will say, do you speak public health? And when I say that, what I'm saying to people is, do you understand what a public health department is and does? Do you understand their capabilities and capacity? Right now, in this very moment, do you understand that public health is seeing more money than it's ever seen before? And that for the next 2 to 3 years, most public health departments are going to have a lot of money. And they're looking for places to make an impactful investment. And when I speak at public health conferences, I often say to them, do you speak EMS? And it's, do you understand the capabilities and capacity of the EMS system? Is it ALS or BLS? Is it a volunteer system? Is it a fire-based system? And typically when I ask these questions, I get some very quizzical looks from the audience. People don't understand what I'm asking. They don't understand the difference. There are a lot of questions, and I get that. And what I'm trying to tell you as an audience is this. We're in the middle of possibly the only global pandemic that many of us are going to see, I hope. And we've done some amazing things in that pandemic. And we've had to. It hasn't been a choice. We've had to wrap our brain around triage. We've had to wrap our brain around contact tracing. We've had to figure out how to vaccinate. We've had to do so many different things. We had to procure PPE, and people are using PPE that they never even thought of using before. And we're using EMS agencies in manners and EMS personnel in manners that we never even thought of doing before. And this is the moment. This is the difference. This is where the rubber meets the road, where you have to say to yourself, what am I going to do with this? Am I just going to go back to a pre-existing crappy relationship with my public health department? Or am I going to seize the moment and am I going to say, you know what? No, I can make a difference. And I'm going to be reaching out to my public health department, to the director, to the deputy director, to whoever I need to keep this relationship going, to keep me on their radar screen. And this is your moment to ask, do you speak public health? And so I'm going to leave some time for questions, but I'll also make it really clear. You can contact me whenever you want. That's my email address. I definitely expect some questions. I'm checking chat right now, but you can also come off of mute if you have any questions whatsoever. I'm more than willing to, and I know we've got at least 10 minutes for questions, so please feel free.
Anybody out there have any questions? Please type them into the box. And
So I will be really clear, that's Ashley. Can everyone hear me okay?
I can hear you, yeah.
Perfect. Ashley, I will email this PowerPoint to Greg, and I think he can send that out to the full audience. Does that work for everybody? Perfect. Any questions, really? Nothing's out of bounds professionally. Notice I had to get that in. That's really interesting. That's a great question, Carl. And I think one of the things that we've tried to do here is really focus on the areas where the State Department of Health has some jurisdiction. So immediately in the beginning, what we did was we made reciprocity, thank you, Jessica. We made reciprocity a lot easier, and we expedited reciprocity. We also allowed EMS agencies to utilize out-of-state providers and even out-of-state ambulances and other response vehicles, as long as they were had been inspected or had credentials in another state. And our rationale behind that here was we kind of wanted to make sure that we were utilizing any and all resources without bureaucracy. At the same time, we also instituted a program here where if your EMT or paramedic had expired within the last 3 years, we gave you an expedited way to get it back right at the beginning of COVID. We kept all of that in place for over a year. And we had hundreds of expired providers come back. And we also tracked how we allowed other providers from other states, but also other states, ambulances, et cetera, vehicles were utilized, and these were all successful programs. We also had a limited pilot program that allowed, typically we want 2 EMTs as a minimum on every ambulance, and we allowed 1 EMR and 1 EMT. And we're thinking about going to that full time. Carl, I hope that answered your question. That was a great follow-up question. Carl's clearly a ringer. We have, and there are various areas in the state that do offer EMT training for high school students. I think it's limited to juniors and seniors, but we do have that, and our Bureau of EMS actually tracks that as well. And what I'll ask is, if you actually want some additional information on that, if you email me at that email that's now being hidden by the chat box, or at least on my computer, I can get you in touch with our state EMS director, and he can give you more information on all of that. Perfect. Carl, just email me and let me know. I'm open to any other questions. Feel free. You can come off of mute, or you can stay in the chat box. It's okay.
I'm trying to figure out a way to phrase a question. So maybe I'll just think out loud, and not that any of us have ever done that before, but in being here in South Dakota, one of the things, obviously, that when I moved from New York City, which has all of the resources you ever want, and I frequently say this, I'd be able to go to a bus crash and get on the radio and say, I need 10 ALS and 10 BLS, and within 5-10 minutes, I'd have another 20 ambulances on the scene with me. And one of the things that we've experienced here, particularly in a lot of the exercises that we do, is obviously, outside of the city of Sioux Falls, which, has about a dozen ambulances, I would say not all staffed at all times. It's predominantly rural here. And so our biggest issue really is recruitment and retention. But during a large scale event like coronavirus, how do you see volunteer EMS providers in rural communities taking the lead as public health experts in their communities as well?
That was really actually a great question. And I have the chat box open, so everybody can feel free to tell me if this is too much of a dad joke myself. But sometimes when I'm speaking about EMS, I say that we live in the world with the rule of threes. And when I first made that comment at a conference. There was an EMS provider there who was shaking her head. And I called on her and I go, what do you think the rule of threes is? And she goes, oh, that's your 300-pound patient on the 3rd floor at 3 a.m. And I could not stop laughing as a former EMS provider, but I said, no. What I meant is that everybody in EMS is involved in at least 3 different organizations. So there's their full-time job, their part-time job, and then there's an other. And that other could be the American Red Cross or American Heart Association Training Center, a DMAT team, you name it. You know, they could be involved with something else. And therein lies our problem, Greg, is that whether it's volunteer or career, we simply have devalued EMS providers to a degree whereupon they know they're devalued and they can be these amazing public health advocates, but we don't pay them like that. We don't treat them like that. And I wish I had a very, you know, open and shut answer for your question. And my problem is that I think my answer is that we need to actually get EMS involved with other organizations that have more power in order to increase the power of the EMS provider. And whether that's a fire department or a public health organization, we simply need to be affiliated with an entity that speaks with a louder voice. And that doesn't mean there isn't a place for a standalone EMS provider. That's not what I'm saying. And I'm not saying there's not a place for a standalone EMS agency. What I am saying is that you need to leverage this moment, much like I said on the second to last slide, to really show people how EMS is the quote unquote Swiss Army knife of public health and how we consistently get things done. And, you know, like, what are you going to do for us as we show that we can consistently get things done? And that therein lies the issue. There's no simple solution, and it's going to be an issue. And I think that the more that public health has relied on EMS during this particular crisis, they're going to see the real value of EMS. And to answer the question that Rob just asked, I have not heard about the specific. I haven't heard specific tribal EMS issues during that are experienced during the pandemic. Although I would have loved to have been a part of Ming Lin's presentation yesterday, because it sounds like a doozy. And Greg, I hope I answered your question.
Yeah, and you know, it's interesting because my argument tomorrow in my presentation that I'm going to be doing is where does EMS actually belong, in a sense that we have, and I'll throw a teaser out there so everyone here will make sure they log in tomorrow to hear me talk, because, you know, I'm arrogant and egotistical. Just like, so, but my argument is actually that we have kind of drifted into the center of nowhere, being drawn away from our healthcare, like, you know, our healthcare roots. And I think that as we got moved into fire service and even NWCG incident command, we got pulled away from our relationships with our hospitals. And the argument I made, I wrote a 20 some odd page argument about this for one of my master's programs. And, you know, as we got pulled into the realm of NIMS, which says, don't change what you do every day. We put EMS into a situation during crisis that we change what we do every day, which is we take patients from the field and bring them to the hospital. And a lot of times we treat EMS like fire and law enforcement, who goes, you know, from the firehouse or from the police car to the scene and back to their offices, being their firehouses or their police cars. And what that does is it kind of takes away from the strength of the communications between healthcare providers. And I think it puts EMS in a very precarious position for barriers to growth, I guess.
I actually agree with you. And I think that this morning, anybody who's on Twitter, please feel free to follow me and I will follow you back. But this morning I posted a story on Twitter about how San Francisco is seeing this in a tremendous increase in regard to in the Tenderloin district. They're seeing this huge bump up in regard to drug use, crime, and unhygienic conditions. And the San Francisco mayor put the Department of Emergency Management into as the lead role. And I'm very tongue-in-cheek. I'm from North Jersey, and so what I wrote was, make sure to consult with checks notes, public health, because like we're like sitting here and like throwing this banner out there about emergency management, but at the end of the day, something like that, that's a public health crisis right there. And the reason I bring that up, Greg, is to tell you that it's not only EMS that suffers in regard to what you just described. Every area does, and every area has to get out there and advocate for themselves to a great degree. And I feel like we have become the entity in EMS that really doesn't. But here's our moment: advocate for yourself. We're coming out of a pandemic where we filled all of these roles. Never been stronger.
Absolutely. And to answer Rob's question a little bit more detail, the tribal EMS is, for lack of a better term, what Minglan was talking about yesterday was, they have people are 90 miles from the closest ambulance or 90 miles from the closest hospital. They are tribal EMS here in South Dakota. And I had made this comment yesterday, like the Pine Ridge Reservation is one of the poorest, when you look at as nations, is one of the poorest nations in the world, sitting right here in South Dakota. And the amount of resource that they have or don't have is significant. So when you look at the impacts on the Native American communities overall, and the healthcare in the Native American communities, and all of the comorbidities that exist within the cultures themselves and the populations, it's a compounding problem. And one of the things that we're trying to do now, so on top of I always joke around at this, on top of my day job is the public safety guy for Sanford Health. I'm also the president of the South Dakota Healthcare Coalition, and I purposefully wanted to see this particular conference focused on roles in EMS. And one of the things that we're doing, and this afternoon, we have the Asper guys coming in to chat a little bit, having some conversations with them on this side about enhancing the role of EMS within healthcare coalitions. Asper requires that EMS be a big partner, but at the end of the day, I don't think we fully embrace them. So our coalition is going to now start reaching out to EMS associations in the state. We have one person who's on our board who's the Ambulance Association president, but also looking at SMEs from these underserved areas to start growing more and more in that role and being part of healthcare coalitions. Because I do feel that, like I said before, they're kind of drifted in the center. They're not firemen and cops, and they're not right now. They're not really looked at from a hospital perspective, as even from a perspective of exercises. And I'm giving away all of my points for tomorrow, but when we do an exercise, we talk about EMS just dropped off 20 patients. We don't always actively engage EMS to be part of that and talk about things like, well, yeah, it would take us 3 hours to drop off 20 patients or 9 hours to drop off 20 patients, because we have massive turnaround times, and we've got 2 volunteers. And we don't have a process for mutual aid that is effective and things like that. So I think that part of getting them into the coalitions is to be able to identify that there are issues, and to use the strength of the coalitions to strengthen our response systems by strengthening their capabilities.
I agree, and that's probably one of the most interesting things when you just said, EMS just dropped off 20. Yes, I do know Brendan McCluskey. Thank you. I just got a private message. Sorry, Rick, I didn't even see that. That was private. I feel like that's probably like one of the foundational errors in most emergency exercises is when I was in New York State, they were doing an exercise once and a nursing home said, oh, if we have 15 patients, I'll just call 911. And I remember thinking, yeah, and they'll have 3 ambulances for you or 4. I don't know many systems, Greg, you've worked in one, but I don't know many systems that'll be like, let me rustle up 15 ambulances for you. Let's be realistic. Let's understand the capabilities and capacity of every one of the single steps of this system so we can exercise appropriately about it. And if we need to expand those capabilities and capacity, we also need to figure out how we're going to do that. But with all this in mind, I know I've probably taken up about an hour of your time. But if anybody, I will send my PowerPoint to Greg to send out. But if anybody has any questions, etc., I think my contact information was all over the place. And I want to say, Greg, thank you. And thanks to the Healthcare Coalition and Sanford Health for having me here. And I hope this has been informative for everybody.
Thank you much, Ray. I know you're a busy guy, and I really appreciate you taking the time out to spend the morning with us. Hopefully we'll be able to get back together sometime on the East Coast. We should have a old home week. We need to put a geolocator on Mr. Phelps, figure out where he's doing. And maybe it's like where in the world farm in San Diego. Where in the world is Scott Phelps? We can start a whole new game, and we can put markers up wherever we get seen.
That's perfect.
Anyone, if you have any additional questions, please feel free to throw them in the chat box. I will send out Ray's presentation, and this also has been recorded or is still being recorded. So we will download these recordings, and we will have links to them on the new. Let me put a plug in here. I know Melissa's out there somewhere. Melissa Ferranda, who is our executive director for the Healthcare Coalition, has been working diligently with our web designer to create a new and exciting website for the Healthcare Coalition. So there will be links to these presentations live or recordings of these presentations out there. And that's also where you'll likely be able to find the copies of the presentations as well for all coalition members. And probably at the end of the day tomorrow, we'll have some more information on how, if you're not a member of the coalition, how to become a member of the coalition, and membership has its privileges. I stole that from somebody, but anyway, Ray, thank you so much for your time. I really appreciate it. Very informative. And we are going to take a 15-minute break, and we're going to queue up Lorraine Giordano for another important chat. And Ray, you're welcome to stay as long as you want. And clearly, you're welcome to come back tomorrow and badger me during my presentation, and but I really, I think we're all on the same page. I think that I agree. It's our time to stand up and shine a spotlight in the work that we all do. So thanks again for your time.
You're quite welcome. Everyone, enjoy the rest of the conference. Take care.
Thank you. Okay, Lorraine, we've got, do you want me to queue up your slides on my end, or do you want to?
Yeah, I think so. I think I'm going to be remaining the flower child here. My computer now advises me it's cleaning up.
All right, so let's everybody take just a 10-minute stretch. We'll kick back off at 10:15 on the dot. Lorraine, I'll have your first slide posted up here, so we know that what you call it, it's ready to go. And then I'm going to stop recording now this presentation,